Hello, friends. Welcome to this month's webinar. We have a very special webinar for you today. You'll notice it's a little bit different in format, and we're really excited about the topic. I have two very special guests with me here today, Mark Newman and Carrie Jones, familiar faces for probably everybody on today's webinar. I'm sure you guys all showed up today just to hear from these two because it's been a while since the three of us have sat down together. So thanks for joining me.
Good to see you both.
I'm excited.
Yeah, I'm thrilled too. You can read the bios, but Mark, obviously, founder, president, CEO of Dutch, the Imagineer behind the Dutch test and the report. And Dr. Carrie Jones, she and I have held similar positions in the company. She was here at the beginning, really helping carve the way for Dutch, and now does a ton of education. She is the hormone queen for sure. And we're really lucky to have you meet here with us today. So thanks for joining me.
Thanks.
I want to start before we talk a little bit about the changes to the report. In actuality, I wanted to start because Dutch has always had a mission to help providers really unlock understanding of patients' hormones. I want to talk a little bit about the why behind Dutch testing because I think it really sets the stage for us as we think about the changes that we've made to the report that you guys are all starting to see, all of our listeners are starting to see. So, the first thing I want to cover, highest level, Mark, maybe you're the best one to start us off in this, but when it comes to looking at hormones, the way you design the Dutch test, there's this estrogen and progesterone, androgens, and cortisol. So, why did you design the Dutch report around this magic trifecta of hormones to kind of get that picture in totality?
Good question. You're making me a little bit nostalgic asking that question because when we were working on the first iteration of it, really before the founding of the company, Carrie was one that I went to and talked to and said, "Hey, here's this concept. What do you think generally? And then how do we tell this story better?" So she's had input on this even before we tested our first sample. So this is full circle or something like that. As we return to the topic of how do we tell the story, but when someone's got hormone dysfunction of some sort, then that can be in a number of places. It can be thyroid, and you're going to get that story out of blood testing. But for many people, there's something in their reproductive and adrenal hormones that's at the heart of what's going on in their dysfunction, lack of health, lack of wellness, whatever it is. And trying to tell that story better is really where this conversation started a very long time ago, of looking at the tools that were available in the industry and looking at the tools that are conventionally available. And if it wasn't for cortisol, I don't know how the industry of specialty hormone testing would have even started, because cortisol you can test in blood, but it just doesn't give you much. And so
Yeah.
that led to the rise of all of these saliva tests and different types of things, because you just couldn't get that story very well out of blood testing. And then there's the sex hormones, which you can tell a pretty good story with a blood test. But as the metabolism becomes into focus, that's where we really have some missing pieces for blood testing. And that's where specialty hormone testing really has taken off. And when we started, it was providers doing very conventional things, or doing a whole lot of specialty testing, in the sense of potentially looking at a salivary test for cortisol and maybe another test for some urine metabolites. And then if that doesn't give you enough of a clear picture, maybe you're doing an organic acid test and you're out $900 and hope that you're finding some answers. And that's the space that we really tried to fill. That again takes me clear back to my first conversations with Carrie so long ago, about like this model of trying to tell a complete story for the cortisol piece, the androgen piece, and the estrogen piece, and piecing that all together with a few other markers to really help people try to find where dysfunction might be coming from, if for a particular patient, the heart of their issue lies in the reproductive or adrenal area for patients.
I love that you're waxing nostalgic about it. Carrie, do you remember that conversation or like how you felt when Mark brought up the idea around this combination of tests?
I used to have a clinic, outside of Portland, and we would meet below it was a coffee shop, and we would meet in the coffee shop in the morning, and we would go over, the test for one, but even, like, marketing ideas and branding ideas, and, like, we would go over quite a few things. And so when I first started working for the test, I often joke, I said to Mark, I'd love to learn the behind the scenes of a lab. Are you hiring? And he said, well, we're a startup, so we don't have any money, but I can give you a lot of urine tests if you'd like to check your own hormones. And I went, okay. So for a long while, I would sit on my couch, and because I think it was the fall winter season, I would watch football, and I would go through all of Mark's emails and tests and reports and comments and all these things to try to help pull together what. And back then it wasn't even called the Dutch test. Mark
Oh,
didn't
that's
come
right.
up with the acronym
That's right.
Dutch until he was on a flight to Australia. But it was precision analytical. It was your dried urine test.
That's awesome. I love hearing those stories of the foundation, and look how far it's come in the last, it's like 13 years now. It's unbelievable. So, Carrie, when it comes to Dutch testing, I think you probably have your finger on the pulse more than anyone I can think of around how providers utilize the test, what they find really easy to understand, what they find challenging to understand. And I want to start with, like, what are the biggest wins out of the Dutch report for clinicians? And what are the biggest challenges when it comes to understanding patients' hormones? And like, how has Dutch kind of filled that gap over this time?
I think it's filled, Mark, I filled a lot of the gap actually. And, Mark mentioned metabolites, but what he didn't mention was that a lot of metabolites themselves are quite
Mm,
active. And so by understanding somebody's metabolites or their hormones, when he says we're going to like really look at the story or, paint the picture, those metabolites being active and going down different pathways is so important to know. So once the Dutch test came alive and people could understand, they understood estrogen because they were doing that in saliva or blood. But once you could see where estrogen was going with detoxification or metabolism, like oh my gosh, the excitement that was around there. Once you could see testosterone and the androgens and then where it was going, the alpha or the beta pathway. Again, people were running testosterone in blood or saliva, but missing this key piece. And then when we got into cortisol, Mark, we added melatonin, and
mm,
having melatonin was just like mind blowing for a lot of people. And melatonin is my actual personal one of my probably most favorite hormones, my favorite antioxidant for sure. And so getting to educate people around melatonin and then the broader picture of cortisol, the cortisol pattern was very easy and straightforward. What was not so straightforward was then they understood the concept of estrogen metabolism, but to actually explain how phase 1 is different than phase 2, how
mm,
phase 2 is different than phase 3, how to explain cortisol versus cortisone. A lot of people thought cortisone because of hydrocortisone cream that's what it was, and didn't understand cortisol is active, cortisone is inactive, and then to layer on the metabolized cortisol, it took some education for people to understand, like, oh my gosh, this is, to use Mark's word, it's definitely a much bigger, broader story, especially if you've been working with somebody and trying to address their HPA axis and it's not getting better, or in fact, they felt worse. And so having this extra information just really was the cherry on the cake, but trying to explain it to a crowd that only did total cortisol in blood or the free
mhm,
cortisol in saliva was definitely an uphill educational battle. And then lastly, the organic acids. Once the organic acids were layered in, much easier to understand, much easier to explain. But even those, that was a lot of extra markers to layer on top of the Dutch test. So the way that it currently stands, it was 6 pages of a lot of information. And Jaclyn, you and I have talked about how the C in Dutch being comprehensive. I'm like, well, it's there for a reason.
that's
It
right.
is definitely comprehensive.
Well, and it's funny because hormones are complex. Like, our hormonal systems
Mhm.
are complex, and I always think about this great, like, side by side picture of Jim Belushi. Remember Jim Belushi, the comedian?
Mhm.
He would, like, be in a tuxedo at the Oscars and look so dressed up, and then you'd see side by side to him a picture in, like, a toga from Animal House.
Yeah.
And I think about hormones much the same way. Like, they have their own behavioral changes depending upon the environment they're in, and the impact they have on our physiology can change depending upon the whole environment. So, and that environment isn't always the same in every organ or every tissue as well. So the complexity of the story layers on and on. And I think oftentimes clinicians oversimplify. And of course, it's partly because we have a tendency as humans to try to make sense of complex things. But I think there's a sacrifice in that where sometimes you miss really important pieces of the story. And when you're trying to put together a treatment plan for a patient with a complex hormone disorder and you don't have enough information or you have the wrong information, it's really difficult to help your patients.
That's the truth.
So, Mark, We've obviously been making some changes to the report over the last 18 months. I looked back, our first release of these last 3, we've had 2, and this is kind of our 3rd and really final big one for a while for the
Right.
well, maybe not, but
Yeah.
for the foreseeable future. As
Future.
far as understanding what's in the report today, this has initially we started with an all-in-one launch to change kind of everything, and then we said we'll phase it in. Talk a little bit about why you wanted to make some of these changes. And let me just talk through some of the things we've done before and what we're doing now. So, March of 24, we changed all the fan gauges to sliders. We also added estrogen metabolism sliders with those specific ratios in there. And then April of this past year, we did a complete redesign with branding. We added age ranges into the androgen dials. We added a cortisol clearance rate slider, which was a new measurement, new calculation. We put 5 alpha androstenediol dial on the summary page for females, which was previously only in the listed table page.
Right.
And then we did some comments changes to kind of clean them up a little bit. And now with this, we have the summary page update. We have some changes to the cortisol graph, which free cortisol graph, which we'll talk about. We added an OAT summary, expanded some of the data on the expanded graphical pages. We added a 5 alpha metabolism slider for progesterone. We've removed the pie chart for estrogen metabolism. We'll talk more about that. And then we've had this complete revision of like the framework which providers can interpret the Dutch test with. This is a big change with the report. But I will, for the listeners, it's kind of our last of like the big changes for a while. So if you ever, have change fatigue, sing
We're almost
it
there.
with me that you can kind of hold tight to this new report format for a while. But can you talk a little bit about why you wanted to kind of revision and kind of have this new Dutch report?
Yeah, I mean, there are a couple different like aspects of it. Some of it is just the science has evolved since we started doing what we do. So the testosterone metabolite 5 alpha androstenediol is the best example of that. Of we threw it in the test because it tells part of that testosterone story. But then over time, the literature has made clear that that's not just a metabolite of testosterone and DHT, but it's actually the best marker, the best way to ask the question: how much DHT, that most potent androgen that we make, not peripheral, not like in the entire body, but peripherally in that tissue that's the target tissue. How do we know that the best? And that marker tells us that story because DHT is made in the tissue. It hits the androgen receptor really hard, and then it gets turned into this metabolite that ends up being really, really valuable. So the science has changed over time in terms of what we want to highlight. That's a big deal. And then probably the bigger thing is just knowing that the way we've told this story and put it together has just not allowed enough for an efficient sort of mental trip through someone's hormone story to pull forward the things that are really important and to try to not get lost in the weeds. I mean, I think it feels like there's a little bit of a movement right now, specifically in the space we're in, to really add more and more and more. And there
Mm.
are a lot of markers out there that have some intellectual intrigue, some academic intrigue, but just make that story expand in ways that aren't tied as tightly to actual clinical outcomes. And so we've been really trying to hone the story to test what's meaningful, what has clinical meaning that we can back up with the literature, some of it historical literature, some of it our own literature that we're publishing, but to put that in a format where the most critical information comes to the top so that you can understand what's going on with that patient with less time spent in the weeds, looking at things that maybe are a little bit harder to understand and their applications a little bit more esoteric. There's a primary story that's complex in and of itself that we want to tell really well. And so when we surveyed our clients and just said, hey, how much time do you spend trying to figure out what's what with a patient? It was not a pleasant data set for us to realize that we haven't done enough yet to put this report in the format where not the Carrie Jones of the world, but the next new provider or the person who's struggling along with this, or the person who has this really broad practice of needing to dabble in the patient's, more than dabble, in their gut health and their sort of standard lab sets of CBCs and blood chems and all of this. And then they still want to dig deep on the hormones. Well, for that patient, or for that provider, I really feel like these are the steps we needed to take to get this into a place where that story can be told efficiently, where the most critical information is brought forward, and there's a little bit more of a linear path to understanding what's going on with that patient as it relates to their reproductive and adrenal hormones. And I really think that this next round of changes, as you said, which have been made in very intentional steps to introduce a few concepts, and then this is sort of the big reveal of like, this is where we're going with this, is to put this in a format where when you orient around this framework, that next new patient that you see, you can really understand most of their story in just a few minutes of looking at that new truly a summary page as opposed to just a few highlights. That's what the first page was, like a few highlights, but people are immediately digging into the weeds because there's some really good stuff there. And I think now with a true summary page, you're able to get your hands wrapped around that patient's hormone story relatively quickly, and then to dive into the weeds that you choose to because it's relevant for that patient, sort of at your discretion and as it is relevant for a particular patient. So the science and an easier story. That's kind of the twofold
Mhm.
direction for us.
I love that. And I think one thing that I would add that really has surprised me, like since coming on the Dutch team and getting the chance to talk with so many customers, is how even when clinicians are really skilled at interpreting Dutch tests, they don't feel like they're there yet. They are like, "Oh, I'm not an expert." And we're like, "No, you are an expert." And one thing I think this report really did and what our team worked to clarify, because we've got 15 clinicians on our team, we really said, what are the essential pieces of information that clinicians need to know to understand how to interpret a report? Because there's a lot of complex additional like cherry on top kind of learnings you can get, and then there's the fundamental elements of the report, and we're going to talk about that today in the webinar. We're going to guide you through this kind of interpretive framework that Mark's developed, but it's really brilliant. And one thing I like about it is that if you are newer to Dutch testing, or maybe you are someone who doesn't feel as confident as you'd like to when it comes to interpreting a report, this is going to really clarify for you that you can like check the boxes. No, okay, I'm actually there. I have the information. Now I can think about some of the advanced concepts to layer in, but that I have the information and the tools I need to help my patients. So I don't want to make people wait any longer. I'm going to go ahead and share. This is a sample report. Let me go ahead and get this up here for everybody. All right. So this is our Dutch Plus report. This is the one that contains the most, the expression of all the changes that we've made. The Dutch Complete looks very similar, and those are our two most common reports. But Mark, do you want to talk us through the changes? This page really is the finale, the grand finale, and everything is here really that you would need to be interpreting Dutch testing from the fundamental perspective. Can you walk through a little bit about this page and why it was designed the way it was?
Yeah, as I mentioned before, it's meant to be like a linear intellectual path through this patient's sort of hormone story, if you will, which are divided neatly into the estrogen story at the top, and then the androgens, and then the cortisol. So those are the three main things that we're trying to really frame well for a provider. So estrogen, androgen, cortisol, and then each of those is separated left and right by hormone production on the left. So you've got estradiol and progesterone. The adrenal androgens in DHEA and testosterone, the cortisol production. You can see the hormone making on the left, and then the key metabolism findings for each of those are then laid out in a corresponding way on the right. So that's the main structure of it, is intended to be simple. Even though we're showing more things on this first page than we used to, it really does tell a quite complete story for a particular patient to look at. Estradiol and progesterone, how do they relate? Okay, now phase 1 and phase 2 metabolism of the estrogen, and then similarly for the androgens and the cortisol, it gives you a really good idea of what's going on. And then as a little bonus, we know that the organic acid markers sort of fold into this story. And so when you get to page 6, you get to recalibrate around,
Zoom
oh,
in
okay,
here.
what does that mean? Well, what we've put on the front page is a little cheat sheet. So for example, if your indican is high, it's going to say GI and dysbiosis right there. And so when you get to page 6, you're going to find that, oh, the indican is high. What does that mean? I've maybe got a gut issue. Now, as I go through this story and I see that this patient has some estrogen dominance, I know that having a gut issue can impact my body's ability to get rid of estrogen, and it ties into that story. And so if you want to tie it into the story as you're telling, describing this patient's hormones to the patient, you've got all of that right there at your fingertips on this summary page. So it also creates one central place to tell your patient what's going on, why we're doing a particular intervention, without necessarily having to flip back and forth between different places. And then again, that's the first layer. And then for each of those layers that you want to dive in a little deeper, E2, yeah, but I want to know about E1 and E3 and 16 hydroxy E1. That's still there on that graphical page that you're going to find as you flip the page. So it kind of divides those basic concepts that tell most of the story, and then the diving into the deeper end and into the weeds is a little bit more at your discretion. So that's kind of the idea of this new truly summary page layout that we're starting the report with.
Yeah, I love that. And I remember one of the conversations we had was even just around the names of the pages, that we really want to present it so that providers can use just this first summary page to talk through results with patients. And rather than feeling like you need to go through every single one, if you can see, if I zoom in here, these are now called expanded estrogen, progesterone, and androgen pages, versus that fundamental summary, because you may not even need to look at these pages in some instances for your patients. It's really just for that deeper story. I want to zoom in a little bit to a couple of pieces of this page to talk about. I want to start first with this estrogen and progesterone and estrogen metabolism section of this page. Now, on the estrogen metabolism side, we've divided to phase 1 and phase 2. Phase 1 metabolism, phase 2 methylation. Carrie, you are so beautiful at kind of describing these two steps in estrogen metabolism. Do you want to kick us off by just, for listeners who are maybe new to this, talking through like what those two phases are and why we look at those two phases?
Yeah, you can see on the left-hand side, you've got the estradiol, and then as you move across to the right, as Mark was saying, we have what's called 2OH slash 16OH or 2OH slash 4OH. So this is the slider bar against the phase 1. So anything where you see the OH after it, that's hydroxylation. And estrogen, estrone, and estradiol have to go through hydroxylation. And I always say it's like my bathtub analogy. It's the water that's coming into the bathtub. We can't turn it off, but we can adjust it. So by looking at those two slider bars, you can see if your water is mostly 2. Do you have a mix of 4 and 16? Do you have 2 on one side, 16 on the other? So it really gives you a good idea of like which way is your patient preferring by looking at the slider bar. Once you get through the water phase, of course, like a bathtub, you have to go through the drain. And the drain is methylation. That's phase 2 or part of phase 2. And methylation is what neutralizes the 2 and the 4 OH, the 2 and 4 hydroxy. And so then you can see like, does my patient favor the better 2 pathway? And then can they get methylated once they do? So in the instance that Jaclyn is showing, not so great. We got a little hold
Not
up
so
there
great.
in not great. Got a little hold up in the little clog in the drain. And so right away, as you're looking at the summary page, you're like, okay, I need to focus on the drain aspect, methylation, and getting it out. And of course, phase 3 is the truly getting it out part. So in the bile, into the intestines, or as of the Dutch test, in the kidneys, and then coming through the urine. So we've got this 1, 2, 3 stepwise process that you can really easy see here on the summary page.
Now, one thing that might be a change, if I scroll down here to our page 2, which is the expanded estrogen progesterone metabolism page. If you've been a Dutch customer for a while, you remember this pie chart. Right now on the current report before this launch, they're both these slider bars and the pie charts here to help you get used to the sliders. But we got rid of our precious pie chart. And
No more pie
I know
chart.
we all love pie. Everyone loves pie. But I want to address this head on because we know that this is going to be an area where many of you are going to say, why did you get rid of that pie chart? I love it. So, Mark, can you talk a little bit about how the science has evolved here, including Dutch has been part of that evolution in peer reviewed literature as well, and really talk a little bit about how providers should be thinking about phase 1 metabolism, and why the pie chart is maybe not the best way?
Yeah, this is something we initiated when we developed the test as an easy way to look at that metabolism. You've got three metabolites. And so the pie chart essentially becomes a three-way ratio of which one is winning. Like a three-way tug of war is a weird PE exercise. Normally there aren't three, but that's essentially what it becomes, is which one of these pathways is really predominating. And it's a really nice first pass way to look at a very, let's say, dramatic pattern. And this is not a bad example, actually. You can see the 2-hydroxys on the lower side, the 4-hydroxys normal, and then, oh, wow, that 16-hydroxy is really big. Well, that shows itself really well in the pie chart. But it's really it's jamming two stories into one story, and it really is better if we separate those, because the 2 and the 16 is telling an estrogenic story. 16 is estrogenic. It hits estrogen receptors. And so if you have high estrogen, that's going to exacerbate a high estrogen. If you have low estrogen, that's going to give you a little extra estrogenic kick. The 2-hydroxy is anti-estrogenic. The 16-hydroxy is estrogenic. That's happening at the receptor. And then we move on to the 4. It's not estrogenic at all. Its whole issue is a different issue in that it can create a reactive quinone, and it can actually attach to your DNA. And so can the 2. So that's a different thing, not at the receptor level. And what we know is that when the 2 holds onto your DNA, it lets go and says, hey, you guys are fine. When the 4-hydroxy attaches to the DNA, it's a stronger pairing. And so it can rip a purine off of your DNA, and that is its genotoxic potential. So estrogenic and genotoxic. And so this is actually a very good case that says, okay, we know of those 3, the 16-hydroxy is predominating, but the 16-hydroxy isn't there at the DNA competing with the 4. It's the 2 and the 4 having a separate competition at the DNA. So when we want to know, well, of those 2, which one is predominating, we're better off looking at a 2-way ratio instead of a 3-way ratio. We've got, a whole bunch of examples stacked up where we can see that in a meaningful percentage of women and men, when the 16-hydroxy piece of this gets really small, but particularly when it's really big, and then I ask you, hey, between the 2 and the 4, who's winning that tug of war? Because it's 2 separate tug of wars, not an awkward 3-way tug of war. And you don't really know unless you're doing your own math and figuring out that 2-way ratio that's sort of buried in that pie. And so when we show it this way, in these cases, again, 2 stories. Which is winning out, the estrogenic 16 or the anti-estrogenic 2? It's the 16, clear winner. Okay, when we look at the 2 and the 4, again, separate issue. And you can see here, the 2 to 4 ratio is actually even more extreme in terms of its balance towards the 4 and away from the protective 2-hydroxy. So when we go to take our data and put it into print, we've now published, I think, 3 different papers on estrogen metabolism, where we've looked at, hey, here's what women look like. Here's what these women look like when they're taking things like diindole methane that pushes down that 2-hydroxy pathway. We've published that for premenopausal women. And then very recently, we published that in menopause for women on patches and estrogen patches, and then estrogen patches, so HRT, with some of these modulators of estrogen metabolism. And we see what we expect to see, that this modulation moves those ratios away from the 16 and towards the 2, and the relationship between the 2 and the 4 is very interesting. And the way that we publish that is 2 different ratios, because that's the direction of the scientific literature. So if we want the story we're telling here to match up with and overlay with what's going on in the scientific literature, then this is really the preferred way to do it. But the more important thing is, again, you will have scenarios when you look at a 3-way ratio where you're missing something significant in terms of assessing the genotoxic potential of the 4 as it compares to the 2. So that was a change that we put a lot of time into. You can see that this is not a full swap. We added these slider ratios. I don't know what that was, about a year ago, to get people used to the story that tells. And then we assess the data to see, like, is it truly better in terms of finding people who have a particular issue in terms of these competitive relationships? And in fact, it is. Again, there's a meaningful percentage where you're missing a part of the story when we don't present it this way. And there really isn't an inverse of that, where the pie chart tells a story that's missed by the sliders. The other thing that you will find, just to let people know, in that space where the pie chart was, is we're going to be able to educate right within that. When we see particular patterns where we want to notify you of something that's particularly noteworthy, that space will be used for that. But that change will be there. And we lament the loss of the pie chart as well, because it is such an easy, nice graphical representation of that. But we think that you will serve your patients better by leaning into these two-way ratios with the
Mhm.
sliders.
Yeah, we need to hold a funeral for that pie chart, but you're right, that blueberry pie, when that 16 was large, we kind of call the blueberry pie internally on the clinical team. It really threw things off. Carrie, for this poor patient on our sample report, what would you recommend for them? How could they improve their estrogen metabolism here? They really would need some help.
They really do, and especially you can see their E1, E2, and E3. I mean, all of them are at the high end of the range, so they have a whole plethora of estrogen coming through detoxification. And so by seeing that the 4 is preferred, the 16 is preferred, methylation is slow. So you have a couple of options. We learn it, I should say, in 1, 2, 3, but you start with 3, 2, 1. So the way for treatment is to start with, like, how is their gut doing? Then now on the Dutch test, you would look at indican, is to give you a little snapshot if you haven't done any kind of gut work with them. Are they having regular bowel movements? Are they hydrated and urinating regularly? And then we move up. We can move up to phase 2 with methylation. So we're looking at methylation factors. We're even looking at things like glutathione and acetylcysteine. We're looking at sulforaphane. And then moving up even from there into the phase 1, we can look at DIM, which Mark mentioned, diindol methane. We can look at quercetin. We can look at resveratrol. So there are, thankfully, a number of supports that we can use, even from a dietary perspective, adding in more fiber, adding in a lot more of the brassica family, reducing alcohol intake or eliminating it altogether, being wary of the medications that you take, the endocrine exposures you have. So there is a lot that can be done in this category on the Dutch test, which is what makes it so exciting and empowering.
Mm, fabulous. Before we go into the Dutch dozen and the interpretive framework, one other area with a lot of changes on the report, I think that are worth covering specifically, are around our cortisol graph. So again, this is the Dutch Plus, which features our cortisol awakening response, or the CAR. But Mark, can you talk through again, like, why do we make changes to this, and what are the things that are going to really be impactful for providers?
Yeah, this isn't as interesting in terms of the science. This is more about just logistics of helping you read something. Is that you can see below where it says waking, it says 4 a.m. and then plus 30 is 4:30 a.m. When people have different and odd times to their samples, you used to have to look up in the corner and then sort of connect the dots a little bit on those. And if they did something odd, it's a little bit harder to see it there. So we've added the times to the x-axis so that it's a little bit easier to see. One of the things you don't see on this particular patient is we've also added the plotting, so putting it on that diurnal pattern when they have a sample collected in the middle of the night to see if cortisol is part of their I can't sleep problem. And then if they happen to collect in the middle of the day around noon, we can add that as well to these. So they're a little bit more comprehensive. And then something that was rightfully frustrating for people is you had to actually read in the paragraph on page 5 what the CAR was, that cortisol awakening response, in terms of its magnitude of change. And you can see that in a nice little table in there in the upper right hand corner. So again, right on that front page, you're really getting a pretty full look at the most important data when it comes to that. And also just some little things, like you can see the 2 are red, they're out of range. The green ones are within range. So that first point is like, it's a little ambiguous. Are we in range or out of range? So just a quick, easy glance, you can see if it's in or out of range. You can see what time the samples are collected, and you can see your calculation for the CAR. And I don't know if we'll get to it here, so I'll just say, when it is a Dutch complete, which is what a lot of you are doing, this is a urine panel. And the one other big change we made to the urine panel is when you wake up in the middle of the night and collect a sample. So not I go to bed at 10 and wake up at 6 and only have one sample, but when I wake up at 2, trouble sleeping, and then wake up and get up for the day at 6, that's 2 data points that we used to merge together mathematically. And then what we would plot was still a 4-point curve, even though there were 5 samples. Now that 5th point will be on there. So you can see 2 things. One is that 2 a.m. sample elevated so as to tell the story of, hey, I've got a lot of cortisol when I'm trying to sleep. Maybe that's part of my problem. And then that second point We want to see where that is as well. One, for instance, that's nice to see there is, if you wake up in the middle of the night and then before you get up and finish your samples, your dog's barking, your kid wakes up, your neighbors are doing whatever that wakes you up, and you're really awake and alert when you're intended to be sleeping. Sometimes you can have that cortisol awakening response while you're lying in bed, not wanting to have
Mhm.
your cortisol awakening response. And in that case, you get a cleaner data point from that sample at waking that you can see is maybe higher than the second one. Sometimes because you've got an issue with your cortisol, and sometimes just because that cortisol awakening response maybe happened during what's supposed to be the sleeping period. So it just gives you a more complete and full look at what's going on with the patient and their results, and when all those samples are collected. So again, just trying to make for an easier interpretation for the provider.
Fabulous. Carrie, I know a lot of providers, like the Dutch Complete is by far the most popular test for us, Dutch Plus being second. But when are the instances where providers should think about doing the DP to capture the car? And maybe just if you can take a minute to describe the car for listeners as well.
And I love the Dutch Plus for sure,
I do too.
especially because of the car. I mean, I think it gives so much information. But when you have that patient that's saying to you, on waking, I feel terrible. On waking, I cannot wake up. On waking, I have anxiety. On waking, I have panic. On waking, my autoimmune symptoms are bad. On waking, my joints all hurt. Like everything's on waking. Now, sure, they may have symptoms, of course, all through the day, but a lot of those, like on waking, that's when, or if you ask the question, like, when do you get those symptoms? And they tell you first thing in the morning, that's when the Dutch Plus will give you so much information by looking at that waking 30-30 mark to see, does your cortisol go up? And I think that surprises some new
Mhm.
people, new practitioners, new clinicians are like, but I don't want cortisol to go up. I thought cortisol caused belly fat and was a problem. Like, no, no, the cortisol awakening response is to go up within a controlled amount and then drop back down the rest of the day. And if that's dysfunctional, then your whole circadian rhythm is off. So
Mhm.
pay attention to those keynotes. My last keynote is ask your patient, how long does it take you to go from conscious to alert in the morning?
Mm.
And if they say to you, oh my gosh, I need like 2 cups of coffee in a couple hours and then I can get going, you know right away their circadian is off, their car is off. Or they may say the opposite. They may say, I wake up at a level 10, I wake up in full panic. Again, you know their car is not good. Whereas they should say, I wake up, I know I'm awake, but I feel within about 30 minutes like I'm going, I'm good, I'm alert, I'm happy, I'm doing my thing in the morning. That's what you should expect. Cortisol should rise within about 30 minutes, get things going, and then start to fall gradually the rest of the day.
Awesome. So I want to shift, like these are some of the major changes. Mark, are there any other big like actual changes to the report before we go into Dutch Dozen that you want to cover?
No, just a few little things along the way. The I think it's noteworthy the page order that now we
Mm,
have some
mm,
phase one estrogen metabolism and androgen metabolism on the front page. So when you want to say, well, here's what that looks
yeah.
like in like the metabolic flow, we've put that right there at page two. Now, it used to be page two is the table, the tabular page. That's now just slipped behind that at page three. So again, just trying to aid for providers telling that story. And then, yeah, the major change, I think, as you mentioned, is this interpretive framework that we're building around that summary page format to just make it a lot easier for people to understand what's going on.
Great. Well, let's move down to that because I think this is another huge win for the Dutch test with this iteration of the report. And honestly, I think this is going to really change the game because, again, it provides this structure to looking at reports in a templated way. And one thing that was really interesting was we talked with our clinical team as we were thinking about how to lay out the report. And we asked them, how do you go through the report? Give me the digest. If I give you a sample, talk me through. I look at this and I look at this and I turn here, then I look at this. And a couple things stood out. One, people were flipping back and forth across pages, which is not an efficient process. And two was that most clinicians had their own way of doing it. It wasn't that we looked at everything the same way. Some people started with estrogen metabolism, some people started with cortisol. And so, what we've done here with the Dutch Dozen is really created a framework based upon our clinical team's recommendations and Mark's brilliance to pull it together into a systematic review of every report. I want to start with this. We call this the Dutch Dozen. You won't see that on the report, but as we talk about it internally and with all of our education, we're going to talk about the Dutch dozen. I want to orient you a little bit that there's basically 3 results pages that cover the Dutch dozen. This is number 2. This is number 3. And what you'll see is each of these visuals, this is your patient's result from page 1. We've just broken it into 3 pages so we can cover a little bit of interpretation of each section of results on a page by page basis. So, Mark, talk us through this first section with estrogen and progesterone. You can see the assessments that we recommend, but can you just kind of walk us through what people should look at in what order when they're looking at estrogen and progesterone?
Yeah, and a big thanks to our clinical team for all that iterative feedback, and then a big thank you to Carrie as well. She served as an advisor in this process of like, hey, I think we've got this about where we want it. Give us some feedback on how we can really lay this out, because she's always been so good at telling the story that comes from the Dutch test, and that's really what we're intending to do here. Is to say that summary page has these 3 sections, right? Estrogen, androgen, cortisol. Let's now look at each one in isolation and load this page with some patient specific comments to help you understand. And this is actually a really good example, but you can see just left to right, we're going 1, 2, 3, 4, and then those 1, 2, 3, 4 sections go down the page to help the provider understand what are the core issues that we need to look at. What is the estradiol? What is the progesterone? And how well is that balancing the estrogen? You can see as well at the top, we're loading up some information that might help. So you can see there that the patient collected on day 51. What does that tell you? Well, they have a highly irregular cycle. You're going to be doubtful as to whether they even ovulated. And then as you get to the progesterone result, you're going to see that result is consistent with someone who hasn't ovulated recently. And so we're trying to break that story down into its core component parts and then help the provider understand what those specific results mean relative to the different reference ranges and some of the context that we want to wrap around that as we move from estradiol to progesterone, their relationship together, and then again that phase 1 metabolism that we just went through at length, as well as the methylation to help break that down. Again, that sort of first pass, first level understanding of really the core key elements for those 3 sections. That's why we've got 12 of them, the Dutch dozen, those 12 key elements that we've brought forward. Now we're breaking them down for people to follow through, follow along with those one at a time to really, again, get that really core understanding of what's going on with this particular, in this case, female patient.
Fabulous. Our next page covers androgens. And Carrie, can you kind of talk through how you might look at these 4 points related to androgens? These kind of next 4 questions in the Dutch dozen.
And I think this is really important because I know there's a lot of confusion given the comprehensiveness of this report around like what is total DHEA? What is 5-alpha androstenediol? How do you even pronounce that? And so I think by having this laid out very similar to the estrogen progesterone section above, like when you go across and you ask these 4 questions about the patient and then see the answers and see the visual, then again, you're just getting a really, 80 to 90% of the information around your patient as it relates to what's going on with their DHEA. How
Mhm.
much testosterone are they making? Are they androgenic? Like, are they going down that 5-alpha DHT, 5-alpha pathway by looking at the 5-alpha androstenediol? That maybe, if you're newer to hormones or newer to the Dutch test, this can feel a little overwhelming with these androgenic dials you maybe have never seen or read about before. And by using these questions with these answers, you're like, oh, got it. Not a problem. Now I understand the androgen section.
Yeah, it can really help to clarify, because those metabolites are active, like we talked about earlier,
When
what that overall load or overall impact could be.
I think just
Right.
if you compare this to where lab testing used to be, um, if you take an old school view of a urine test, you don't see total DHEA production on the left, and you don't see 5-alpha metabolism slider on the right. What you have is you have a table, and in that table are
Mhm.
a bunch of things you can hardly pronounce. There's etiocalanolone, there's androsterone, and they have reference ranges. And then if you are willing to add those things up and somehow compared to what's normal, you'll have an idea of this marker on the left. And then if you take the ratio of 2 of those, it'll really tell you whether the patient's pushing down the alpha pathway or the beta pathway. And asking a provider to do that is such a heavy lift, and
Mhm.
it distracts you from the key story. Like for me, myself, I am a heavy 5 beta metabolizer. What does that mean? Well, what that means is that my testosterone moves away from DHT down the non-androgenic pathway. Why I'm still balding, and that's true, I don't know. That hardly
We
seems
could have
fair.
never, Carrie and I could have never brought that up, but since you
But
Yeah,
mentioned it.
since you said
but
it,
but
that's different
what that
genetics.
means is it tells me my adrenal androgen production. I'm going to see that on this front page. I'm going to see that I push away from DHT. But the fact that etiochalanolone is high, like that's really something that you'll find in that very detailed page. And you can just get lost. The key relevance of that can get lost when you're not pulling forward what that really means. Is it's implying this about my adrenal androgen production overall, and it's
Mhm.
implying this about the way that my testosterone is being metabolized. And digging further than that, isn't that helpful? And that's what we're really trying to get at here, is get to the crux of the issue, because that's what's going to lead probably to intervention. And we don't have to weed through all of those things to try to pull that forward. And that's the main vision of this.
That's great.
And I think for people who like women with PCOS, sort of that like I call it like sneaker PCOS where
Mhm.
their testosterone is in range. They have all the symptoms. They're clearly PCOS. They go to their primary care who's like, I don't get it. Your testosterone's in range. It's not PCOS. They do a Dutch test, and all of a sudden you see those two markers on the right. 5 alpha androstenediol is really high. They're leaning onto the right, like they're high. Their 5 alpha reductase is high, and you're like, there it is. It's the next layer down.
This is a classic picture of that too. I mean, this particular case
Yes,
we're showing you is a fabulous example of that. And this is where the metabolite testing really shines. And because you see that if this was measured in serum, this patient would not have been out of range, most likely.
correct. Yeah,
When you're looking at DHEA or DHA sulfate in serum and you're looking at testosterone, most likely this patient's serum measurements would have been normal. And the reason why they're having so many androgenic symptoms is not related to those parent hormone production. It's related to how they're metabolizing. And that when you see that side by side, I mean, you can see here that 5 alpha androstenediol and then the metabolism being pushed to the high 5 alpha. That's what's driving symptom picture. That's what's driving anovulation and what's driving maybe the hirsutism they might be um, presenting with. So I love this side by side view. The third page, we've talked a bit about cortisol, but we haven't really talked about the cortisol metabolism side of it. So when we're looking here, first thing to do is take a look at that daily free cortisol pattern in the car. If you're looking at Dutch Plus, then we can report that saliva cortisol total, which is a sum of all of the points. That's number 2. You can see that labeled here on the dial. Then we look at how much is metabolized. Now, this is a really interesting concept. I don't know if either of you want to comment on this, but this really hit me hard when I first saw the Dutch test and metabolized cortisol and learned about this concept. Because when I was in school as a naturopathic doctor, maybe at the time there wasn't as much available, but we looked at salivary cortisol diurnal pattern curves, much like we see here on the left. And if I saw a patient like this, I would have been like, wow, they're really underproducing cortisol. Let me help them make more. Let me maybe give them licorice to help them preserve it. But I would be thinking we need to boost their adrenal production of cortisol. But with this added piece of metabolized cortisol, where you're seeing how much is being made, you would get a completely different assessment for the patient, which is that they're actually making a ton of it. They're just not keeping it around. And that really hit me because it made me think back to my years and years of practice where I probably made mistakes in prescribing for my patients when it came to how I could best support them because I didn't have that information before I started doing Dutch testing.
and we would hear it too. We would have practitioners. I mean, some practitioners, would just use regular everyday adaptogens or vitamin C, and so like that may work out fine. But others, just like you said, Jaclyn, were like, oh my gosh, I need really heavy hitters, so to speak. I need to get the HPA axis to really work. I'm going to use stimulatory herbs as we know them. I'm going to use maybe even use
Cortef.
cortisol
Right.
itself. Yeah,
Yeah.
exactly. And all of a sudden they're like,
Right.
my patient feels worse. They're doing worse. They're anxious, they're jittery, they're gaining weight. Like what's going even more weight in this case, they usually with that high metabolized cortisol, I would suspect some visceral adiposity there. And so when we see this picture right away, those of us, who've been using Dutch for a while go, oh yeah, they don't need a lot of stimulation, like major stimulation like that. It'll make it worse.
Mhm. Mark, what are some of the things that drive this pattern that we're seeing here with that high metabolized cortisol?
Well, one thing nice about this pattern is, as we're talking about change, is this section uh, presents a little bit differently, but this data is already on the summary page, so this will not be a lot of new information from people. And this is actually the number one driver of the development of the Dutch test, is this idea of taking the cortisol story as we know it for free cortisol and adding in that better marker of overall production. And the number one reason that we see that in people is, as Carrie mentioned, is obesity, is having this cortisol sequestering organ essentially around your waist that can pull in cortisol, and then eventually that ends up in the toilet as a metabolite, and your body's got to keep up with that. And so when you see, a heavier patient that looks like this, yes, we want to support their HbA axis, but we, as Carrie really well said, we don't want to do it in a way that's super stimulatory, because we're probably not going to get the results
Mhm.
that we want in that case. If you had a patient that you accidentally or whatever gave way too much thyroid medication, that could lead to, a similar story where you're just really cranking through that cortisol. And there are a couple other cases, but those are probably the two most common ones where we see this type of story, with the lower free cortisol and the higher levels of metabolites. And we just want to be really thoughtful about the way that we treat people. But if you take that Dutch test extra information away of the metabolites, to your point, Jaclyn, it's just really easy to run confidently in the wrong direction in
Yes.
terms of what your patient really needs.
Yeah, you'll be running your patient toward a brick wall. It won't be very pleasant for them. Mark, what does the cortisol clearance rate slider add to the picture here? And this is something we added in April. Again, we kind of knew we were coming in this direction, but we wanted to introduce clinicians to the concept. Tell us a little bit about why this is an important piece of that cortisol story.
Yeah, the concept's been there since day one. We're just making you do mathematical gymnastics in your head when you look at the free cortisol and the metabolites and go, okay, this is an obvious case, right? Free cortisol's low, metabolites are high. Okay, that tells a really nice story, but we're just doing the math for people here so that we can simplify how much thinking they need to do and push their thinking towards the why question. Like, why does my patient look like this? We don't want you to be spending quite so much time with your calculator or abacus or whatever, trying to figure out if you think that their rate is actually slow or that sluggish case where we're thinking about hypothyroidism. I want you thinking about hypothyroidism, not about division, in terms of math. So that's all that is for, is just to help people cut to the chase. And also it gives you a little better idea of, like, is this an extreme pattern or is this a
Mm,
modest pattern? So that's a population percentile. So it's small on my screen. I think it says 97%,
I
but
can
that
zoom it in for
means
you here.
your difference between free and total for metabolites is higher than 97 out of 100 people. So that's a pretty extreme
Pretty
pattern.
fast.
And yeah, and
Mhm.
we want you, to respond in light of that. But yeah, that's just doing math for people, to help them cut to the chase.
Great.
And what's interesting is when you talk about like treatment options, sometimes people will say, well, wouldn't this person be tired? I'm like, they absolutely could be tired. Their free cortisol doesn't look all that great. But how do you address it? As Mark said, this could be hyperthyroidism or too much thyroid medication. Maybe if you have them on a lot of free of T3. Maybe you have them on a lot of thyroid supplementation. Maybe it is the opposite though. Maybe it's visceral adiposity, inflammation, high insulin, and you're going to treat those very differently. If you have somebody on way too much T3, that's different than, wow, they're really inflamed and hyperinsulinemic. And so by looking at this, it helps at least narrow down the paths you have to look at. If they're not on thyroid medication or thyroid supplements, then you're like, cross that off. That's
Mhm.
not the issue. Let's move on to the next thing.
Great. Now, in our last few minutes, we've covered the fundamentals here. And I mean, I think we all agree that if you can wrap your head around these concepts that we've talked about that are part of the Dutch dozen, you are most of the way there in helping your patient and it kind of coming together with what's going on with their hormones. But the thing that's unique about Dutch is there's so much more nuance to it. And we would encourage you to focus on learning these fundamentals first. But I know that there's many of you who are listening who are like, well, what about cortisol to cortisone conversion? Or what about catabolic or anabolic patterns? I know you guys are out there because we talk to you every day. So to kind of cover that, we have developed what we're calling the advanced insights. You can see these pages either at the very back of the report. This is not our final version. These are still getting updated, and they will continue to evolve over time and become more and more specific to your patient's results. But Mark, can you speak a little bit into how these are covered, how they're kind of tied into the Dutch dozen, and how providers should maybe dive into one at a time to learn those concepts in a bit more depth, to really just layer on and layer on and layer on the learnings that they can get out of a Dutch report for their patient.
Yeah, I mean, I think it is important to note that you don't need to master each of these before you start using the Dutch test in your practice. But I think the metaphor of peeling an onion is really appropriate for this. That first layer, you don't want to use the Dutch test, a lot in your practice if you don't understand those 12 key and core things. But once you're comfortable and past that, it's not the next step is not to understand all 12 of these. I think taking them at the most relevant at a time or one at a
Mm,
time as you kind of work through these is a perfectly reasonable way to do that. And of the Dutch dozen, all of those are relevant. They're not all going to be dysfunctional, but they're all relevant to check for every patient, in my opinion. But when it comes to these, some of them will not be relevant for a particular patient, but for others, they will. And they follow what I think makes this a little bit more manageable is it follows the same cadence as we went estradiol, progesterone, phase one, phase two. And these advanced insights follow that same pattern as we dig deeper. The Dutch dozen, you only need the front page to really understand. For these, for each of them, you really need to go to page 2 and page 4 and look at some of those more complex concepts, but we're going to break it down for you in bite-sized pieces. So estradiol, right? That's the main thing that tells me what's my estrogen status. How estrogenic is this patient? Okay, but we want to dig a little further because we know that while estradiol is the most potent estrogen, there's also a fair amount of estrone, E1. That's also estrogenic. It's about 20-25% of the estrogenicity of E2. Same thing with 16 hydroxy E1, and it has this unique quality that it covalently bonds to the estrogen receptor. So those two add into your story of estradiol. So if estradiol is in a particular place and those two are both much lower, you may have less estrogenic load than you think by just looking at estradiol. At the
mm.
same point, if estradiol is, like in this case, estradiol was a little high, right? But if
Yeah, I can hold
E1
that
is
up if you want to
super
look.
hot and 16 hydroxy one, which I think it was in this case, was super hot
Mm,
in the sense of being more elevated than the estradiol, it's going to exacerbate that potentially estrogenic picture. That's exactly what we see there. Estradiol, you can see there at 4 is high normal, and then you go down to your lower right, and 16 hydroxy 1 is
this
out of
one here.
range high, meaning that kind of estrogenic patient is going to be over the top estrogenic with this particular picture. And that's just one example. Like, we're not going to teach through all of these today, but that's just one example of how we can see estradiol opened up. What's the next one? Progesterone. And if you go up just a little bit there, Jaclyn, you can see zoom in on that. One of the elements that we added to the test, which in this case doesn't really matter that much because their progesterone is low. But when you put someone on progesterone, some of the impact, as a lot of you know, comes not just from progesterone, but from its metabolites. Well, which metabolites? Well, those alpha or A metabolites are more potent when it comes to the analgesic effects, the sedating effects of progesterone. This gives you a nice, easy way to see, do I push it in that direction? You can see for this particular patient, again, they're lower, so the significance is not that high, but she's pushing her progesterone towards that allopregnanolone, those more active sedating metabolites. And when a patient's on oral progesterone, that is the deeper issue. That is the
Mm,
advanced insight that we're going to open up for you for progesterone. And again, phase one, methylation, and then we go to into the androgens and looking at some of those individual patterns and things that are at a deeper level that you can unpack from this page, but we're going to help walk you through it. With cortisol, we talk sometimes about, cortisol is that most important thing, but the cortisone that you see on the left of this page, in some cases, all it does is confirm, yep, you are understanding that correctly. But when it's really different than the cortisol, we're going to help walk you through, what does that mean? How does that actually change the conclusion I have about this patient as it relates to their cortisol status? So again, for each issue, we go through the 12 basics in the Dutch dozen, and then with the advanced insights, it's a deeper understanding of each of those that you can, as the comment will sort of help you and imply, when it is highly relevant for a particular patient, it's worth considering that as well as you dig deeper on some of these issues to become truly a hormone expert. And we're going to facilitate that with these patient-specific comments that, as Dr. Smeaton mentioned, are going to continue to evolve over time as we dig through the literature and dig through our data and publish data, we're able to make that a richer experience for you in understanding and leveraging just as much as you can this test for your patients.
Absolutely. So I know we're kind of coming to the top of the hour here. I'm really grateful to everyone who listened in. I want to point out that we have so many resources and trainings on these changes on the Dutch Dozen, but you're also going to see this coming out in our education. We have Dutch classes that you can sign up for with our clinical team members, where our docs will be going through the Dutch Dozen and some of the advanced insights with you on a case by case basis. You can learn a lot more. And stay tuned because we will be launching some exciting new, including live in person events next year, to really be able to dive into this soup to nuts and walk away with what we're calling exposure therapy, where you get so many cases to walk through that we're sure you're going to walk out feeling really confident in your ability to cover the Dutch Dozen and also the advanced insights when you're working with your patients. So stay tuned for that. It's going to be a quick sellout, I think. And thank you, Carrie and Mark, for joining. Dr. Carrie, if you had to sum up like these changes here, the Dutch Dozen, advanced insights, the report changes, what stands out to you as like the most impactful thing that you're excited about?
And you and I have talked about this before, but I think changing comprehensive to clarity.
Mm.
I think by having just looking at that first page on the summary page and just having like those 12 simple questions to walk you through versus the amount of panic practitioners I get who are like, it's 6 pages. I don't know where to start. I don't know what these comments mean. Now it's like, oh no, we just literally follow the yellow brick road. It will be fine. And you will feel so much more confident at the end.
Follow the yellow brick road. I love that. Mark, same question to you.
I think yeah, just the pathway from I'm overwhelmed to I understand and I can help my patient. I mean, our mission here is to help providers profoundly change the lives of patients. And when some of the insights for the Dutch test go undiscovered, that's a
Mhm.
missed opportunity. And I think this is going to help providers help their patients more. And feel more confident as they use this in their practice. And so we're just excited to be a part of that journey. And I'm thankful for the both of you for being part of our journey of getting better at how we tell this story and unfold this for providers. So I think the amount of help that you've both had along this process of refining what we have and how we present our testing for providers has been super helpful, and I think it's going to continue to impact providers and then by extension a whole lot of patients. So I'm thankful for that. So thanks for being along for the ride.
You bet. Thank you guys
Yeah.
all for listening with us. We look forward to seeing you next time.